recordings, don't you? Okay, so now we're just doing the roundup for the case studies for this week. And the first one, I think most people looked at it, and once we got the right numbers, and I'll make sure that I change those numbers on the slides that go up into echo. So we're going with a red cell count of 3.83 because I want you to have, and that using that red cell count, you should have got an MCHC of about 320. So what I really wanted you to find here was that the red cell morphology was mainly microcytic hypochromic, but the majority of you, I think, saw that there was actually a dimorphic blood picture there, and this is probably because the hysterectomy was done because this patient had trouble with bleeding over a fairly, over a few months, and so they decided to remove the uterus to control her bleeding. And so what we're seeing here is the, if you like, it's the bone marrow is recovering from that, and I would suggest that at the same time she was being given some iron supplementation, and that's why we're seeing the dimorphic blood picture here, particularly the reticulocytes that we can see. So the sort of results that you should have gotten for this would be something along the lines of microcytic hyperchromic anemia with reticulocytes, well, reticulocytosis. And then this might lead you into query iron deficiency anemia on treatment. That's probably the most likely cause that we're seeing here. And then predicting the results of the iron studies. Would anybody like to have a go at what you think the iron studies results would look like? So when we're looking at our serum iron, no, okay, yep, so serum iron, yep, so do you think they would be all low, Kiani? The serum iron certainly would be low. Exactly, yeah, not the total iron binding capacity, well done. So that would be increased. So if we have a look, as I said, so there's anisocytosis, poikilocytosis, polychromasia, hypochromasia, and hypochromia there as well, and a few other things. And then everything low except the iron binding capacity, so diagnosis of iron deficiency anemia. Okay, so if we go on to the next case study, and if groups 1 and 2 can lead us through this one. So the questions, that's the red cell morphology, so perhaps we can start there with what you see with the red cell morphology and how that matches with the results. Anybody in groups 1 or 2?
Sure. So we can see microcytic red cells, and that makes sense of the low MCV-ish, potentially, compared to the nucleus of that small lymphocyte there.
Mm-hmm.
We had a long discussion about what the inclusions were in the red cells, whether they may be Pappenheimer bodies associated with like sideroblastic anemia, or actually Hal-Jolly bodies, and we couldn't decide why they might be there.
Yeah, there's probably there certainly is a couple of inclusions there, but on that film they're very difficult to tell what they are. Yeah, so you'd probably be looking for a little bit more a bit more testing to see what those are. But you probably leave those to one side for the moment. So going with the history of the person, and the fact that the MCV, it is microcytic, but it's really only just microcytic, isn't it? So normal MCV is about 78, the lower reference interval. So what did you come up with as a provisional diagnosis for this one? Anybody in either of those two groups? Someone apart from Jordan? You don't have to talk, you can type. Yeah, so anemia of chronic inflammation, yeah, because that's, again, that's probably the most likely given that history. The inclusions certainly you'd want to keep in mind, but go ahead and do some further testing. So what other further tests did you decide to do? Some of the cells are hyperchromic, Gabby, not a lot of them though. If you have a look here, there's a few hypochromic cells, but the majority are normochromic there. And that really does fit in with anemia of chronic inflammation, because usually it's not a very significant anemia. So a hemoglobin of 96, that's sort of on the cusp of being mild to moderate. And we can see some hypochromia there. So it could also be, what else could it be? Anemia of chronic inflammation, and because of those hypochromic cells, what do you think it might be? Some sort of an early version of? Yeah, it could be an early IDA happening as well, because remember, with anemia of chronic inflammation, you can also get an iron deficiency anemia, as not because of the anemia of chronic inflammation, but you can get that alongside an iron deficiency anemia alongside of that as well. So sometimes that could be the case. So, whoops, I've jumped ahead. What about the further diagnostic tests that you decided with these? Anybody in those two groups apart from the people who've already contributed? So you think you've got, yes, you could do high sensitivity CRP, but if you think that you've got an iron deficiency anemia there, plus or the rheumatoid arthritis, what's the main test that you would do? Sure, iron studies. Okay, so this, I don't know why I've got dimorphic there. It's not really all that dimorphic. But yeah, so it's definitely something that you would want to look at. Chronic inflammation, early iron deficiency. Again, because of her age, you might consider sideroblastic anemia. And the other thing that you might also want to consider is an abnormal hemoglobin variant too, because remember, with some of our abnormal hemoglobins, we can get sort of that sort of cuspish lowish MCV. And iron studies will differentiate all of those. And that's just a slide directly from your lecture from yesterday that shows you how they're differentiated. And so you can see here that these are the iron study results in the middle here. So you can see that iron studies is quite a useful test for when we're looking at these sorts of anemias where we've got frank microcytic anemias, or where you've got an anemia that's sort of just normocytic, but you know that there is often a, like an iron dyscrasia behind it, such as in sideroblastic anemia and anemia of chronic inflammation, particularly in older people. Okay, so this was actually a case of anemia of chronic inflammation. So well done those people who were working on case study 2. So that's what we would see in the bone marrow. So these are our bone marrow macrophages, and they have got, that's hemosiderin that is being stained in their cytoplasm there. Okay, groups 3 and 4 with case study 3. if you'd like to lead us off here. So we've got 60-year-old male, complains of tiredness, history of chronic bleeding and prostatitis. And there are our results. And again, there is our blood film morphology. So perhaps you'd first of all like to comment on that blood film morphology.
It's microcytic and very close to being hypochromic.
Yep. And do you think all of the cells look the same, Kiani? All the red cells?
Definitely not.
No. So again, we've got that dimorphic population, haven't we?
Yes.
So there's a couple of instances here where we've got a dimorphic population. So we've got that microcytic hyperchromic blood group, plus we've got the normocytic normochromic there as well. Okay, and I think you were actually given the iron studies results for this one. So when you had a look at all of those results, perhaps somebody other than Kiani this time, so Kiani's done her bit. So if you first of all can give a summary of your results and give a provisional diagnosis. What do you think's going on here? So remember, your provisional diagnosis is fairly broad. Sorry, Charlene, go.
Looks like a microcytic anemia with a dimorphic blood picture, and the iron study supports a sideroblastic anemia.
Right, excellent. Okay, so if we just looked at that, and that's correct, well done. If we just looked at those FBE results, what other things would you have to consider? Perhaps somebody else from that group. Yep, so some sort of an iron overload. So that would be looking at those, the iron studies results, but just looking at the FBE results, not at the iron study results. Yeah, not so much from the FBE results. Forget about the iron study results. Just look at these results here and this history. What else would you have to consider? So we've got sideroblastic anemia. Yep, so again, it might be a hemoglobinopathy. Yep, what else? What did we say for the case study 2? Yep, chronic blood loss. Okay, thank you. Yeah, it could be ACI as well. So prostatitis could be ACI, and chronic bleeding could give us an iron deficiency anemia. So you are correct that this is sideroblastic anemia, and the serum iron studies help to, the iron studies help to determine that. It's not going to be hemochromatosis, because hemochromatosis gives you a normal FBE, okay, normal blood picture. So you would absolutely definitely do a bone marrow in this case, because that is how sideroblastic anemia is diagnosed. So what we're looking for here are these ringed sideroblasts. And so the ringed sideroblasts, just to remind you, are erythroid precursors, where the iron is not able to be incorporated into the heme ring, as opposed to iron-laden macrophages, which we see in anemia of chronic inflammation. Okay, so I'll let you go and prepare for your test for cell and molecular, unless anybody's got any questions. No? Okay, well, thank you very much for your attendance, particularly as you have got a test coming up in 2 minutes. The mid-semester test, thank you, Amelia. Yes, that will be online. So if you have a look, in content on Milo, I've got a page, an HTML page for week 7 with information about your mid-semester tests. I will be updating that information as I get more information, so please keep going and having a look at that. Okay. All right, we'll leave it there. Thanks very much.